Well, hello everyone. Uh, Good morning, good afternoon, and good evening. My name is Justin Pauly. I'm the Executive Director of International Affairs at VXPASS. We're very excited today to have the founder of VXPASS, Zachary Weiner, and our esteemed friend, CEO of Greystone Group, Dr. Chris Gibbons. And today we're going to be talking about the future of blockchain on healthcare, amongst a myriad of other just what's fresh and exciting with technology and healthcare and how they're coming together. Dr. Gibbons, thank you so much. And thank you to all of our panelists and all of our guests that we see here, all of the attendees. So thankful that you can join us today. So without further ado, I think we can get right into it. So the broad topics of conversation we're going to go over today is two types of technology to begin with. Things that enable more efficiency and things that are brand new. And so with that, Dr. Gibbons, if you could tell us about the advantage of this combination of information and efficiencies. Perhaps, I think we discussed earlier about the diabetic example, and I think that's a great place to start for those who really want to see what the future holds.
Sure.
And with that, Dr. Gibbons.
Sure. Thanks so much for having me. You're exactly right. There are a number of ways of thinking about developing and looking at innovation and improvements. Many people focus on doing things better than what we've done before. And at some level, that is innovation. That is something that's important to do. But an entirely different type of innovation is an innovation that allows us to do something which was never possible before. And those are the types of innovations that are often, especially when they have broader impact than the thing you immediately designed it for, those are the innovations that are termed disruptive, because they change not only what you designed it for, but they have much broader implications on the business, on the field, on society even. And there have been a number of disruptive innovations, although not everything that everybody's calling disruptive truly is. One of the examples that we talked about of an interesting innovation that points to the future of healthcare, which is already available. So a lot of what I talk about may seem like it's futuristic, but some of it is already here and much of it will be here soon. And so that's why I think it's so important for us to not only be thinking about innovations that help us do what we normally do, but innovations that are really game changers for that future that is upon us. The continuous glucose monitor is a type of medical device that, as you know, diabetics, people who have a disease that causes their blood sugars to go too high, and some of those have to take insulin shots in order to bring it back down. Well, insulin is a very powerful drug, and we have to give different amounts depending on how high your blood sugar goes. But your blood sugar goes up and down for a whole lot of reasons every single day, from what you eat, the types of things you eat, how much exercise you're getting, how sedentary your lifestyle is. And so we need different amounts of insulin throughout the day. So normally people who are insulin dependent diabetics, they have to prick their fingers, get a drop of blood, put it on a test strip, and then put it in a monitor. And a few seconds later, the monitor tells them what their blood sugar is. And then based on what we call a sliding scale, you look up or you're told, this is what your blood sugar is, this is how much insulin you need, you draw it up in a syringe, and you give yourself or someone gives you a shot of that amount of insulin. It works, but it's difficult. People don't like giving themselves multiple shots or getting multiple shots. The whole process can be cumbersome. But we now have on the market these devices called continuous glucose monitors, which are very, very interesting because they all at once can detect what your glucose level is. That information gets sent to the cloud, or even can be done peripherally in the machine. And it automatically determines, based on you and your biology, how much insulin you will need. and then automatically at the same time gives you that amount of insulin. You don't have to do a thing. The doctor doesn't have to get involved at all. And if you need insulin 3 times a day or 5 times a day or 10 times a day, it'll determine that and give it to you 3 times, 5 times, 10 times a day. This is an example of innovations that are really game changing because they're changing the paradigm. And we're going to see many, many more of these kinds of innovations coming not only into society, but in the health space as well.
Yeah, and that's great. And I think also as blockchain people, we always want to make sure that we say, and there's less room for human error. There's no transcription. There's no, I have to count it, are my, whatever those things come into play. So we always like to be extra precise in the blockchain world.
And to reiterate that point, right? In this case, the advancement is that these are computer-aided decisions. So while there is efficiency in the time it takes to diagnose the amount of insulin and apply it to the body, that's an efficiency gain, but offloading that responsibility to a computer is entirely new for our generation, so that's
absolutely right. And, for those doctors who are not using this, and most doctors, quite honestly, are not using this device, many of them feel like it's a problem. Oh, is the device can be trusted? Or on the other extreme, is it taking away our jobs? As we develop more of these things, will we just, go into oblivion because they don't need us anymore? The computers can do everything. But quite frankly, those physicians who actually use it, many of them think it's the most amazing thing. They love it. Why? Because they don't have, it's something that they can offload to the computer, which frees them up to do other things, sometimes, things that they couldn't get to because they were doing this with all of their patients. And so it's a different world. It's not a world in where we don't need doctors. We will still need doctors. The computer can't know what to do unless a doctor or health professional has been involved in designing and putting together the algorithms and the decision trees and informing the AI and the machine learning that has to happen in order to make all that happen. So the roles that doctors have may well change somewhat, but we will not go to a world where we don't need any doctors.
Great. Yeah, we had a funny discussion with a doctor in UNICEF who's in Congo right now, and she said, we love this concept, but we're still battling it. More people die of measles than from COVID right now. So again, everything is localized. For us, our needs are different as we expand globally, right? Those healthcare. And she's like, I would love to just work on measles, right? If I just could, sign up for your computer program and not have she called it a computer program, but whatever, right? She goes, and then we just don't have COVID here. That's great. Like, we have plenty to work on. We don't need any extra. I really don't want to take away time. And so I think that's where technology can then shield them from just kind of the mundane stuff. Not that COVID is mundane, but being able to check and be able to operate freely and securely. So thank you, Dr. Gibbons. And please, for all of our attendees, please send away those questions in the chat. If you haven't open chat already, please do. We will sort of, after we get through 2 more questions with Dr. Gibbons and some lively chats, we're going to play a 2-minute video, which just is a very base example of how VXPASS works. So keep those comments, and while we're playing the video, I'll go through the comments and pull out the relevant questions, and then we can shoot those over to Dr. Gibbons, and that will sort of be our schedule today. So please be active in the chat, and I think we can sort of move on. I think Zach wanted to talk about the value of data being available to anyone with permission on a single interoperable ledger, because that is something that in theory is happening, but not in one ledger, but there is interoperability. And for those of you who don't speak medical data jargon, that is the ability for what? Yeah.
Is that it's the inability for systems to share data, right? And so there are large programs, human efforts to standardize that data to allow systems to use the data created by another system. But if we had just one sort of global source of truth where permissions could be allowed for that data to be read by professionals, can we talk about the value of having all of that data in one place as opposed to the way it may be distributed today?
Sure. As with everything, there are advantages and disadvantages, pluses and minuses, pros and cons. And this is really no different. Right now, we in this country, in the United States and many countries around the world, have a healthcare system that is extremely fragmented, extremely. The data is in one place. The people are in, the providers and professionals are in one place. The consumers and patients are in another place, and support personnel are in another place, and the systems of paying for it are in another place. And making all of that work together is a monumental task that I think at best works sometimes, but works well not so often, and works well for all very infrequently. And because of just, if you don't even look at the specific elements, you just look at the fragmentation alone, some people have a better ability to, when they fall through the cracks, get back in. Others don't. And so the fragmentary nature of our system is very, very problematic in a whole variety of ways. Even in delivering care, a patient might come to one provider and then go to another provider. And if that provider knows nothing about what happened before, he's at somewhat of a disadvantage in providing the care. One of, as you mentioned and alluded to, one of the big projects or ideas in healthcare is to try to make clinical data interoperable in the way that wherever the patient goes, that data would be available to whatever professionals or others that the patient wants that data to be available to will be there, so that at least that problem of being at a relative disadvantage because something may be going on or have been documented that you don't know about will be eliminated. And there's a lot of work going on in this area. We're not there yet. We're getting there. Many have alluded to the fact that blockchain technology and distributed ledgers may well be the technology that could enable that to happen, and ultimately bring this reality to life.
Zach, I see your trumpet,
Yeah,
but if you want to add something to that, absolutely.
I'm personally a believer that when data becomes accessible, we learn to use it in ways that provide a larger benefit than maybe what was originally intended for that data. And Dr. Gibbons, you had discussed with us an example where that happened with a Fitbit and a jogger. Right, somebody's Fitbit was able to be read by the medical practitioner. So can you tell our audience how that data that wasn't necessarily intended for a hospital became valuable to them?
Right. So yeah, I'll tell you the example and then we can talk about it. So as you know, there are now any myriad number of wearable devices that we can wear that now track data about us. And while many in the health profession originally thought that those types of devices were rather worthless, they might give a false sense of safety or security, but many early on in the healthcare, particularly providers, didn't think there was much value. Their notion was if that information didn't come to the healthcare system and interact with the doctor, there was not much value there. That I never understood, quite honestly, why they believed that. But then a few years ago, I stumbled on this example. It was a real life example of a man who had a Fitbit, and at the time was out jogging, and something happened, and he lost consciousness and fell out on the road. Well, fortunately, some people were able to get him to the hospital. And in the emergency room, the doctors actually were struggling to understand what was wrong. And that's the first step in treating somebody appropriately, right? They noticed that he had a Fitbit on. I don't know how they did it, but they were able to get into the Fitbit, get the data out of the Fitbit, and it had a cardiac tracing, and they were able to diagnose a special type of heart abnormal rhythm or arrhythmia, for which they were then able to treat the person, and the man is alive today because of that. And so it was a great example of how data that at least some people thought was irrelevant to health actually saved this man's life. And again, I think you're going to see, we're already seeing more of that. You're going to see much, much, much more of that as we go forward.
So let's take that even further, right? So let's take, okay, lucky chance found a Fitbit. Let's go proactive. So talk to me about perhaps a room for an asthmatic in the future.
Yeah, so a lot of people are excited about wearables and what they can do, and it is exciting. It's still relatively new. But if you just push yourself a minute, think beyond. It's a great idea, but has some limitations, right? I mean, how many things can a Fitbit count or keep track of? How many data elements can they keep track of? I ask a lot of people that question, and the same answer sort of always comes back, I don't know. Well, I don't know either, but what I do know is that it's a limited amount. You can't track infinite things in one Fitbit or one iWatch or one smart piece of clothing of some sort. So, but what if you're the person that needs that other thing monitored that's not connected in your Fitbit or the iWatch or whatever it is that you have? What are you going to start wearing 2 Fitbits or 3 watches? Or, I mean, so you can begin to see the limits of that technology. Once we get beyond that, it's less useful. So then what happens after that? Do we say, okay, that's the end of the innovation and that's where we stop? Well, that's the business that I'm in. We think about those things and try to think about the future. And what we've said is, well, the next iteration of it would be not to put these technologies in the things you wear, or the things that you turn on, or the things you carry, your laptops or your cell phones, but to embed them into the environment itself seamlessly, and they almost become invisible. So what does that mean? Well, instead of putting it on your wrist, the same sensor or similar sensors are built into your home. They're built into the walls, they're built into the floor, they're built into the chairs that you sit in, they're built into everyday life. When you're walking down the street, they're built into the street lights, they're built into the park benches you might sit on in the park bench, they're built into your automobiles, they're built in everywhere. Well, why would you do that? Well, then the same kind of processes could happen, but you don't have to be involved. If these sensors were there detecting information, that information was interoperable with some intelligence, a cloud-based system or an edge-based system where it could then be analyzed, and if the appropriate algorithms and infrastructure was in place, it could determine what's going on and then execute a command, which the system itself could then follow. You could have a whole new paradigm of healthcare. Let me explain. Let me give you an example. So for example, let's imagine you live in, sometimes these are called smart homes, but now most people, when they talk about smart homes, they're talking about, eco-friendly and low carbon footprint. And I think all that is fine and good, but we can get explicit about health. And that's where we spend a lot of our time thinking about how technological opportunities and smart things can be explicitly better for health, not just sort of, oh, there's a health benefit too. So let's imagine you're living in one of these homes that has these sensors and hooked up into the walls. And let's say you have a young son or daughter that has asthma. Asthma in this country is a very prevalent disease. A lot of people have it. It's so prevalent that we're not scared of it anymore. But I actually have 2 young friends that while we were in high school and college, both had asthma, both died of it. One was playing on the basketball court, had an asthma attack and couldn't get to the sidelines fast enough to get his inhaler. The other one was playing on a football field. Same thing happened, had an asthma attack, couldn't get to the sidelines fast enough to get his inhaler. And so although we have treatments that are fairly effective for it, if you can't get to them, they can't help you. And so that got me thinking. And so imagine now, you live in this house and your son or daughter at the age of 5 or 6 or 7 has asthma, as my young son did when he was that age. He's now in his 20s, but he had it at that age. And so every night we would put him to bed, but we would wonder, is tonight the night that he's going to have an asthma attack? And if he does, are we going to hear it in time to get up and run into his room and give him his inhaler so that he'll be fine, because he was really too young at the time to do it and to know all that by himself. Fortunately for us, when that did happen, we were able to hear him, and he's fine today. He's grown out of his asthma. But just imagine you're back there in that world, and you tuck your daughter or your son to bed, and then you go to your room or go back downstairs, and tonight is the night. Your son and daughter or daughter has begins to have an asthma attack, and with the first phase of that we call increased work of breathing. It gets difficult to breathe for a variety of reasons. Well, now your son or daughter hasn't actually woken up yet. You don't know anything about it. You can't hear it. You're in a different room, a different part of the house. But now the house has these embedded sensors, and within a fraction of a second, notices that this has happened. It analyzes what is happening, what it detects, in combination with data about your son or daughter from their electronic medical record or from their past history and other ways. It determines that your son or daughter is about to have an asthma attack. And then that same system issues 2 commands, but not to alert the doctor, not even to alert you. It sends 2 commands back to the house. Why would it do that? Well, what are the 2 commands? One is raise the humidity level in your daughter's bedroom. Why would it do that? Well, when you take your inhaler, or say you have a worse case of it and you have to go to the emergency room and they give you a nebulizer treatment, that's what you're getting. You're getting moist, humidified air. So that's the first thing it will tell you. So out of your vents or your heater, the humidity goes way up in that bedroom where your daughter is. The second command is to give 2 puffs of albuterol. Albuterol is the medicine that's in the inhaler that rides on the moist air to get into your airways and stop the attack. So again, out of the vents that used to just be heat, now you're going to get 2 puffs of albuterol in that room. And all of this happens within a few milliseconds. And your daughter's impending asthma attack is aborted before she even wakes up and knows there's a problem. And you know nothing about it until the next morning when you check your phone, your email, or your device, and your home alerts you to what has happened. Is that healthcare? Of course it's healthcare. Did it involve doctors and things the way we do it today? No, it didn't do it at all, but it just saved your daughter's life. That's the world that's coming.
Amazing. So I think just to keep on schedule, we have a ton of great questions coming in from the attendees. And so I'd like to speak about gamification very briefly. Then we're going to go to the video and organize some of the questions, which are a lot of blockchain related. So I think the question we were going to get to first was about, so when you say something triggers the alarm and it checks your records, who owns those records and where are they stored? I think we're going to get back to that after the break, but I'd like you to speak quickly about how gamification can help increase awareness and understanding of people and how they process through the healthcare system, and how do we get them more involved?
Sure. So, I mean, quickly, just because something is good for your health doesn't mean that everybody's going to do it. Or just because you have a device that could help you doesn't mean that everybody's going to do it. Just like because we have a vaccine doesn't mean everybody wants to take it. But what we do know also is that games for a large number of people have the power to get us to do things that we might not already do. Social media involves an element of that as well and gets us to do things. What do I mean by that? Well, some of you may have heard of Groupon. It's a web-based, internet-based service that sends you coupons to your home for all kinds of things. You get good discounts. Now people are buying things that they never would have bought before, simply because of that gamification of the shopping experience that's offered through Groupon and many other. Living Social is another one. So the idea is that perhaps if we could add game elements or gamify some real problems that we have out there, we might be able to not only to get people to shop when they don't want to shop or buy things they wouldn't ordinarily buy, but we may be able to get them to initiate behaviors that are actually helpful to their health, improve their longevity, and lead to a better standard of living But it's the gaming element or the gamification of the process and the issue that makes it more likely for the behaviors to actually occur. So there's a lot of work going on in that area as well.
Absolutely, yeah. Healthcare has a lot to learn from, the people who sell Cocoa Puffs, right?
And the most basic example of that, right, is people who walk around looking at their rings on their Apple Watch. You know, it's a simple trinket of a sound or a visual cue that you've hit your mark for the day. You've earned your award, and it convinces people to stand up at the end of the day and take a few more steps.
No, I think that's a perfect example. I mean, just the little like button in Facebook, there's a whole lot of science behind that, and how that like button makes you keep coming back for more. It's the same thing. Well, why can't we be thinking about these things in the context of not just getting people to open their programs and buy something, but, change their diets, be more active, take their medicines, see their providers, interact with others, increasing, social interaction. All of these things have been correlated and are known when you don't get them to decrease health. Well, why don't we focus our attention on using some of these elements that we know work in the context of new technologies that are available to people wherever they are, whenever they need them, to improve health.
Wonderful. All right, so that seems like a natural stopping point for us to now show the video of this gentleman, Zach, in a different colored shirt, going on for about 2 minutes about how cool VXPASS is, and it really is amazing. If anyone would like to have a live demo or talk to me about implementation, my information will be at the end, and be more than happy to reach out and discuss.
So before we play the video, guys, feel free to continue posting your questions in the chat or the Q&A. We're going to be reviewing them as you watch, so you still have time to get them in.
Yep. Yeah, and they're fantastic questions. So please keep them coming. How much farther and faster would we have if government could get their stuff together? Yeah. We could spend a whole week on that one. So I will play this video. And I will read and direct the questions after the video. We just sort of have to organize them so that we're not overlapping, and then that should be good. So without further ado, I think this is going to work.
And today, we're going to walk through how VXPASS works. And we do that as easily as clicking the New Patient button. Now you'll notice we didn't ask for any personally identifiable information. Those things are not attached to your account on the blockchain. Now the patient is going to place their QR code in the view of the scanner so that their ID can be read, and the provider application will check the blockchain to see, in this case, if the patient has any receipts or stamps on the blockchain related to vaccine. So we've been presented with a send button on the lower right-hand side. When the provider clicks the send button, the application writes a receipt or a stamp to the blockchain that the patient now owns. It includes some details about the manufacturer, the lot ID, the expiration, also that the patient can own and retain that information when coming back for their second dose. And then in a few days, the patient will check again whether or not they're eligible, simply by scanning just as they have before. The provider application has gone and checked the blockchain and sees that for this patient, even though the data was created by another medical practitioner, for this patient, we can verify that they've received the first dose of the Moderna vaccine and they're within the window of receiving the second vaccine. So we'll go ahead and inject the vaccine, and then all the nurse or practitioner has to do is click the send button. The first dose was administered properly, the second dose was administered properly and within the time window, and now the protocol is complete. The last step for them is to check their completion status. At this point, we'd expect that they've been completed or that the protocol has been completed. This demo was completed in very short order, and you were able to see blockchain, security, data ownership, and health records, all demonstrated very, very efficiently. Thank you again. I'm Zachary Weiner, founder, VXPASS.
Hi, and we're back. First of all, thank you so much for all the questions to the panelists and in the Q&A section. I, of course, because he is a good friend, and we'll reach out to Pafane first, if that's all right. For most African countries, technology has almost every time been tied with, it raises concerns they may lead to discrimination for the poor and exacerbate existing inequalities. How can this notion be killed or stopped in the distribution of COVID-19 vaccination? I represent Lesotho Private Sector Fund, which will be buying the vaccines for the Basotho people, and will be using VXPASS. Thank you very much, and for the verifications of inoculations. So I think inequality is a cornerstone of what we have, Zach has been building out since the beginning. And we look at it as getting the vaccines is an inequitable process. Receiving them, manufacturing them, they'll always go to the highest bidder, that type of thing. But what we can make democratic and have equality as the basis of is the verification process, so that anyone who wants it can get it readily, and we can put that together just as we have, and we will be implementing that in Lesotho. So for the vast majority of the Basotho people, they will have a vaccination verification on chain in the next couple of months. And Lesotho is a beautiful place that is probably not high up on the median income level. And so if we can make blockchain work in a place that has perhaps less resources, then one would expect that blockchain would be tested. And I think the inequitable part of that, the argument sort of fades away, because Lesotho is going to be leading the world in on-chain verifications of COVID, which is the most amazing thing. And I think that's such a tremendous story.
Moreover, if I may, just to abstract, from what you were talking about specifically about Lesotho to the broader scale, I think what we find, especially as journalism is able to uncover some of these inequities, is that the more data we have around where vaccines have been distributed, the more the inequity surfaces. And until we shine some sunlight on the problem as a whole, but individual areas where the inequity problem is occurring, there's very little way to garner the type of support that would render the need for a system that describes everybody equally. So while the systems that are in place are able to sort of hide that inequity in ways that they've grown accustomed to over maybe 30 or 40 years of doing it one way, or slow change in the medical community, as we start to publish some of this data to a globally accessible ledger, right, where all of the data is available in near real time, that's validated by the medical practitioners who are doing this type of diagnosis or this type of injection, the data that surfaces allows the people who have the most at stake to prove that inequity exists. And so sunlight is the greatest disinfectant. Additionally, I'd just like to make one more point about VXPASS specifically, not related necessarily to blockchain, but VXPASS is built specifically to be able to handle serving people who don't necessarily have a smartphone. And so the interaction with the system is not dependent on the client side or the patient side on network communication. Meaning we could hand them a card with the QR code the same way that a patient may get their QR code from our app, but that just takes a little bit more planning and execution. You have to print those cards, they have to be available, somebody needs to be there with a printer. It's much easier and more efficient to use the application when people have smart technology. But we've kind of looked at these as considerations for what what oversights may occur from technology companies like ours that add to the disadvantage, and what can we do to solve those problems before they become an issue?
Yeah, I would add to that. You're absolutely right. Issues of inequality, disparities, they were around before technology happened, right? But we live at this amazing point, in my view, where while we have not been able to, for the most part, eliminate them before technology, we have the potential with technology to eliminate many, if not all of them. But the questioner has the right perspective. If disparities are not a technological problem, they are a problem of society, of politics, of will, of it's not even an issue of money all the time. But technology could help us address those problems. However, if we don't roll out technology equitably and build it in a way that is meaningful for these populations, not only will it not address these disparities, in my view, it will serve to enhance them and enlarge them faster than we would have without technology. So it's a double-edged sword, and the technology is a vector, is an enabler of one thing or another. What actually gets enabled is up to us.
And I think that gets back to maybe the gamification, good marketing, clear and insightful and precise communications from the medical community. You know, one voice, no crazy people on Facebook kind of thing, and be able to have the adoption rates that we would like to see, especially during a pandemic, right?
Yeah, I mean, data transparency is always important to facilitating trust. Our healthcare system in this country, perhaps those in many countries, I don't know as well as I know this one, has an issue with that. Trust has been lost. Our government, maybe governments in many nations, has an issue with trust. And so building trust doesn't always come so easily, but it can be done. And in addition to the things that you're saying, just in general, understanding and working with the people that you are trying to target, not just tell them everything, but hear from them and involve them in the process. Those things help to build trust over time. All of those will be needed, not just for vaccines, but if we're ever able to get over these problems more generally.
Okay, I think our next, and Dr. Gibbons will probably have you start, and then maybe Zach can follow up on the end with this one. This is from Mr. Gomez, and a ton of great questions actually from him in both the questions and the comment section. So I want to make sure that we're putting this together. What technology can solve massive problems that seem very expensive, and government seems not to support scalable products? That is probably a very accurate statement, although not a question. The government continually supports products that do not scale well, and then they, even though everyone told them every time that you're going to get into trouble eventually, they never believe us. But with blockchain, it is different. It is infinitely scalable. And then we're going to get to his other question. How do you secure privacy of that data? And is there any universal blockchain, or it needs to be private? So I think part of that is just a defining, and then how do you assure privacy of that data?
You're directing that to me. I think maybe.
Yeah, let me take the lead on that one.
Okay, let me take that one first. It was more about how do we get these types of things in the government that are expensive, and why do they continue to make to us it would be seem short-term solutions instead of understanding the longer-term implementation.
We live in markets that are federations generally, and so we encourage, for most of the way that we run society, we encourage small incubator systems to come up with innovations, test them, prove that they work, and then allow that to scale or move to a larger scale. Oftentimes, the things that work regionally don't work when you get to a larger region, maybe the size of a large country, maybe the size of a continent, but becomes even more problematic when you scale to the size of the globe. So I don't necessarily think it's the government supporting unscalable technologies. I think it's the government supporting what works when they need it, and maybe what works best and can be explained well at the time there's a need. But what ends up happening is because those localized systems, those federated systems are not incentivized early on to be thinking about the global scale, we end up with systems that have problems when they try to reach the global scale. Okay. And then if we go into the blockchain question here, right, which is there a universal blockchain or does it need to be private? The blockchain that we've chosen to build VXPASS on is both global, or all three, global, publicly accessible, and privatized. Okay, so the idea here is that while the globe can interact with the network and the actual data that's stored within that network is accessible by nearly anybody, if you want to protect your data, it can be encrypted by your account, which is your public key, in a way that'll only allow you to view what's there stored in the record. We can allow some of the data to be stored in a private manner and some of it to be stored in a public manner. For example, on VXPASS, we store a lot of data in plain text. And the reason for that is simply so that medical professionals, technologists, and governments can go take a look at what is in the records on the blockchain and see for themselves with human eyes what they're looking at and what they're reading. Okay, and so if we take that and extrapolate it to the federated system, it's hard to go top down and get everybody underneath to agree on a system that works. So we face this sort of double-edged sword where the incentive is to start small, local, and build up, but that poses huge risks for when we get to the global system. And for the people who start or attempt to start at the global side, they're sort of disincentivized by the lack of ability to raise revenue or get clients on board right away, and to focus on the smaller niche problems. And that leaves us in this space where the two don't necessarily connect in the way that the patient would hope for. So I hope I was able to address the data side and the blockchain side of that. Dr. G, is there anything you'd like to add?
No, I think you
Okay.
handled that pretty good.
Dr. Gibbons, we have a flurry of questions directly for you. Greg asks, do you know if these kinds of tech developments are being introduced at medical professionals early on, i.e. in the university or training stage, or are they going to be typically exposed first at the post-qualification? So practicing doctor. And I think that raises a tremendous question about how we get to, as Dr. Gibbons mentioned earlier, they continuing to do what they were told because that's how they were taught. And I think this is a great opportunity to maybe your first year of med school should be understanding futurist, right? What's going to be happening. So make sure you're prepared for it when you get into the field, as that medical field should always be changing and adapting. But Dr. Gibbons, please take it away, as you are a doctor.
Yeah, that's a very good question. I've been doing and focused on innovation and technology in the health space for 20 years now, and that means I started when technology really wasn't even a thing in healthcare, long before EMRs, long before all of that stuff and getting in place. So what I've seen over those years, and I'm going to be quite honest with you, is, and this is true not just in healthcare, it's true of every sector, right? That change comes hard. Change is difficult. And most of the time, the people who control whatever it is that they're controlling, whether it's a sector or an organization or a family or whatever, they tend to keep things the way they have been going, as you said, because that's what they know what to do, know how to do, and that's what they know, and that's what they've been brought there for. But change happens anyway. And Clayton Christensen, a Harvard Business School professor, wrote a book, The Innovator's Dilemma, which looks at this very question: why do big businesses absolutely fail? And he said, matter of fact, it's one of the most enduring insights you can get. Very, 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 very few, in fact, no businesses that survive forever. No businesses survive forever. Very few are able to survive for hundreds of years. And it's all because of this reason, because most businesses do something when they're small to get started, that catches on, they get big, and then they keep doing that thing forever. Even when their clients, the patients, and the world around them changes, they keep going full steam ahead. And that allows other startups and other people to develop the things that the new world is looking for and will buy. And by the time the big guys figure it out, it's too late.
So we have another great follow-up question to that. And it says, this is from Neil, and it says, how can blockchain technology help integrate healthcare payments, insurance data with EHR clinical data? Payment data is used for all kinds of policy decisions. So here's where we're getting to being able to turn this very large ship of, how do you adapt, right? Slowly, but it has to come with policy as well.
Yeah, I think so.
Can it lead to better access and quality of care? And how would that look like?
So again, I'm not your typical doctor, so I'm going to give you an example. I'll give you an answer that you're probably not expecting. First of all, that question underlies a perspective that I think personally, based on the work we've done, is a little bit faulty. You're asking the question as if tomorrow's healthcare is going to be paid for the same way today's healthcare is paid for. Your underlying question is that tomorrow's healthcare is largely going to be done the same way, organized and delivered the same way as it's done now. I think all of that is not true. And there's already examples of how that's changing right in front of our eyes. And it's a perfect example of what I'm talking about, of those of us in the field oftentimes ignoring what's really happening out there and trying to just layer on technology to what we're already doing to make it better. Healthcare is changing fundamentally at its core. How it's getting paid for, yes, it's still largely paid for by insurance, but maybe you've heard of a little company called Amazon. Maybe you've heard of little companies like Apple and all the others. On September 24th, I'll give you one example. September 24th, 2019 is probably the most significant day in healthcare and digital health in specific that most people in healthcare didn't even notice. Well, what happened on that day? A number of things happened. I'll talk about one quickly. On that day, Amazon announced that it was jumping into healthcare significantly and opening what they called Amazon Care, which was an entirely virtual clinic. No brick and mortar involved at all. If you needed to get in touch with a provider, you interface through your phone, through text, and within 10 minutes, a nurse will call you. What healthcare system does that now? If you needed, you could get online and get in touch with them, whatever. If you needed more and needed to actually be seen, a provider, a nurse, or nurse practitioner comes to your house. You don't go to any hospitals. It comes to your house. And oh, if you need medicines, guess what? Guess who prescribes them and gets them to you? Amazon. They own a pharmaceutical company, PillPack, right? And if you live in the right area and have an Amazon Prime account and also have an Amazon Go account, those medicines will be at your door within 1 hour of ordering them.
Isn't that amazing? That we've come full circle with the doctor with the leather medical bag coming to your house on horse and buggy. Right. Call the doctor.
That's exactly right.
It'll just happen a lot faster.
One little piece I want to add to that because it hits at what he's saying. When I talk about that, sometimes providers will say, well, that, they're not getting reimbursed for that. And I'm saying that's exactly the point. Do you think Amazon is giving this away for free? No, but they figured out a business model in order which they get paid for it without insurance at all. And I gave multiple talks after that day. I said, watch this space. This is going to grow. They started it. It was just in Seattle for their employees in Seattle. Some of you know where I'm going. They announced just this week. Last week, they announced that they filed paperwork to take it to 21 states. Yesterday, they announced they're taking it to all 50 states. Healthcare is changing right now, but we're still trying to operate the way it was done 20 years ago.
I'm just responding to Mr. Gomez. He said, can you put the date of Amazon Care in the chat? There you go.
September 24th.
Thank you, Andy.
19.
Thank you.
Oh yeah, there you go.
I wasn't quick enough on the typing.
If I may, I'd like to extend that answer a little bit just into the blockchain space. Yeah. Okay, so I think generally speaking, if we think of what happens in healthcare, I'm not sure that the fundamentals of at least the base of a transaction are going to change all that much, right? So whether the transaction is between you and a live doctor or you and a virtual clinic, you still have to have some exchange of information. That might come from your wearable that goes immediately to the virtual clinic before you even get there, right? So that they have an understanding of what you might be coming for. But I think along the way, the patient's privacy and the ability to track what has occurred so that it can be paid for will stick around. It may look completely different than what we do today, and the model of who pays for it may be different, but this idea of interaction, support, and cost can't change all that much without changing money, right? Or changing how society is built. And I think that infrastructure that we just talked about, the future infrastructure, is uniquely primed and ready for a system that is readily available across the globe, so that I, as a traveler, I met Justin in 2016 traveling, can get the same type of care in Thailand as I might at my more regular home in Florida, but can also regularly see the same health practitioners, or be able to necessarily share my data and allow myself to be charged from some healthcare provider in Malaysia. But the underlying system of secure, nearly anonymous but pseudonymous transaction data is the perfect place to store this type of interaction data that may or may not come down to cost. Okay, so maybe you get a treatment that costs you some money, but maybe you get a treatment that was paid for by a sponsor, right? They're going to show you 6 advertisements before they ship it out to you, because they know you're waiting for the confirmation code, right? And you get 6 1-minute blips or 1-second blips. Fundamentally, there is no infrastructure today that could compete with blockchain, specifically something like Bitcoin that is ubiquitous, in order to be able to provide the base layer for those interactions. So by having built-in privacy and ownership from its very core inception, it kind of positioned itself to be readily available for the needs of this particular vertical and the way it may be changing, probably while they were still thinking about it as money, before it became a data storage facility. And I think that's really interesting and unique from the perspective of EHR data and paying for it as we move to the future that Dr. Gibbons was just talking about.
Yeah, I mean, it's complicated, because what you may not fully understand, Zach, is the changes that you were talking about underlying it. While they may be true, most people in healthcare, even till today, cannot conceive of healthcare being financed in any other way than the way it's financed today. I can't tell you how many colleagues over the years have told me, Chris, yeah, you're probably right in the stuff you're doing, but I'm not going to engage it because there's no way for me to get paid for it. But in other words, there's no reimbursement for that thing. Do you understand what you're saying? You're saying there might be a better way to do things, but I'm not going to think about it or do it because I can't get paid for it. Healthcare is the only industry that you get paid for doing subpar work. Think about going to the auto dealer and buying a car that is known not to work fully. Would you accept that? I mean, come on. So we're inhibiting innovation by thinking that way in the healthcare field. So those outside the healthcare field at Amazon and other places are figuring it out and bringing it to healthcare, and healthcare is going to be that giant that goes away, at least the way it was done before, if they don't hop on board and start trying to figure out some of these things for themselves.
So I think our last question, and I have a comment, and then I'll open it up to you guys. So how much faster and farther could interoperability proceed if not been a deal with HIPAA and injecting federal funds into HR development, essentially less government oversight and the gating? So I do want to speak to Pafane, who is the leader of the public-private partnership and in Lesotho, and they have a very specific thing, and this goes to who pays, right? So when the person, the paying group, in this case, a public-private partnership that was mandated by the government. So the government said, you're going to be able to respond quicker than we can. That's just the way it is. and they get the blessing and they're off to the races. And Pafana and his group were very forward thinking, and they go, look, we're paying for this. We need to have it verified on chain because we can't afford to lose doses. And I think as we move forward, people are going to get more critical of healthcare in terms of why is there so much perceived waste? And I'm sure there isn't a lot of waste, but it's part of that perception. And so I think as the payers get more, can tighten those reins, as the public-private partnership absolutely should do. They're trying to reach the most amount of people the quickest in the most efficient manner, which part of that is price. And part of that is verifying that what they have is actually working. So I'd like to ask Dr. Gibbons on a global scale, how that may look in the future with the payer, whether that's an insurance, whether that's a governmental organization, or whether it's a public-private partnership, on how we tackle these things, both with the immediate COVID pandemic and then ongoing, essentially, maybe blockchain EHRs moving forward.
Yeah, it's a good question. So forget the argument about who's going to pay for it now, whether it's going to be insurance companies or government or private entities or yourself or whatever. What is true is somebody's going to pay for it, right? It may be a lot of people, it may be a few people. It's somebody's going to have to pay for the goods and services that are used. That's not changing. And so if we are to have a global system that is interoperable, and what that means is, frequently a lot of my colleagues in healthcare talk about interoperability only in the context of data. Data is important, but it's also in the context of services as well. I mean, data means nothing without the services and goods that go with it. So it's not just about getting your data transport. I will take, just in your example, just one step further. If you're, I think you said Thailand, and you could get good care over there if you have an interoperable system. I said, well, if you have a good interoperable technology-based system, you could actually be in Thailand and see your same doctors in America. I mean, that's what's going to be possible. It will not matter where you are to what types of care that you can receive. It will not matter if it's available locally or not. It will be everything if we have the global infrastructure to do it, for not just payments, but also for organization and delivery of care. Those things can be delivered at the point of need, not just at the point of care, a hospital, a health system, a doctor's office, or even your home. Wherever you are, whether you're under the bridge or by the beach, you'll be able to receive the services that you need if we have that global infrastructure. Blockchain, distributed ledgers technology may well become part of or form the basis for that technology. But again, we'll still need people to agree and governments to agree and work together to get there.
Absolutely. I think that speaks highly to equality in terms of getting healthcare, right? If you're not near a cardiologist, or, is this something that needs to be concerned, and then the records could just get pinged and they can. So I think that's tremendous going forward. Zach, do you have anything to add in? You are on mute just before you.
Thanks. Yeah. So I want to reiterate, one of the advantages, and medical professionals, sort of get this innately, right, is the more data you have, the more informed a decision you can make. And specifically, when we talk about things like clinical trials, right, these are individual people who make a discovery or an idea or have an inclination on a small scale. And then that small scale idea is proven, and others start to peer review it, and they can replicate and see the same results. As we expose those types of data, doctors are very used to reading these periodicals and understanding maybe the changes in the landscape from peer-reviewed articles. But the data underlying it becomes more valuable as more data can relate back to it. So even if we just remove the payment conversation for a minute and talk about, in the same way that having publicly accessible data can help to shape the conversation around inequality by pointing a spotlight at the most inequitable locations, I think it can start to do the same thing for what we call treatment in addition to coverage, right? So it actually ends up leading to better outcomes to allow more of this data, not your personal data, right, but the outcome data, to exist in a place that's accessible by any of the researchers who want to access it, who need to use it to make inferences about their own research and to make that nearly immediately accessible, right? It's like the second generation of the leaps and bounds that medicine took when the internet was enabled. And so the internet was enabled to share data immediately, and we built these silos around authentication and authorization and email addresses and sign-in. But if we were to just sort of abstract all of that stuff away and leave the relevant data in a place that was accessible by anybody who wanted to do the research, I think we'd cut down on a tremendous amount of either A, people being dissuaded from furthering that type of research because of how difficult it is to get the context around it, right? Or B, the amount of time it takes to set up your research to get the contextual data. So if we can cut down the times on either one of those two, we're going to lead to better outcomes. If we can create more data that presents stronger cases for, maybe seemingly counterintuitive ideas, that's going to lead to better outcomes. And the more of this that's accessible by new systems that come online, by new app ideas that come out, by new machine learning or AI that figures out how to work with the data, the more advancement we're going to see piled one on top of the other on top of the other. Instead of waiting a year or 18 months to see the next leap or advancement, it's going to come out 3 months later and then 6 weeks later. So, the impact on how healthy we are, it may not be able to be explicitly measured right now as the impact on positive outcomes, but the impact of individual positive outcomes stored on a global ledger that's accessible by any researcher that wants to find it will lead to better outcomes for all of us over time. It's already proven to. Now we can just share the data and learn faster.
Yeah.
All right.
Go ahead. I'm sorry.
No, I was going to say, and I wouldn't be doing my job as the MC here if I didn't wrap it up somewhat on time. So, Dr. Gibbons, of course, as our honored guest, please allow yourself the last word. And then thank you again for all of the attendees and panelists. I really appreciate everyone's time. Dr. Gibbons, to you.
I was just going to offer a little insight on what Justin just said. It's true. One of the things that we know, one of the most effective ways to help ensure doctors do the right thing is to make their data available about the outcomes that they get, whether it's available to them only as doctors or to patients. Nobody wants to be an outlier. And when you see that you're an outlier, you often do the things that you need to do to become not an outlier. And that actually was part of the basis of some forms of health reform that policymakers have been looking at over the last few years.
Well, that's wonderful. And thank you so much. I have put my, email in chat. So if anyone would like any follow-up, please contact me. We'll be happy to discuss any and all questions, and you can email me anytime. Thank you again, all. We very much appreciate this this kickoff VXPASS webinar, and we'll have more to follow. So please be aware, look for those invites and send out to others who may be interested as well. Again, my name is Justin. I'm the International Executive Director for VXPASS. Zachary Wiener, the founder, Andy, US Operations, and of course, the esteemed Dr. Chris Gibbons. From all of us to you, we appreciate your time and thank you so very, very much.